Dr. Hicham Kobeiter will talk about management of difficult anastomosis, tips and tricks.
Good morning. Thanks a lot for the invitation. I'm really happy always to come back to see my friends in Egypt, Karim, Ahmed, and Shakir, and Wael, and all of you guys. So, complex anastomosis, I find like all the anastomosis are sometimes complex. That's no simple anastomosis. Some of the anastomosis are nice, but not all of them are easy to deal with. So anastomosis is, definition is a communication between the prostatic artery and other arteries that's supplying mainly the bladder, the rectum, and the penis. And we will see it in the majority of the case, especially if you inject selectively and if you inject with strong power. Really, I think we could see like 100%. I don't know what you think, guys, but we can see anastomosis in 100%. If you inject really hard, you could reopen all the shunts, and so you need to really manage how you do your angiogram and to see what are the possibility to avoid having problems of non-target embolization. And there's two options if you want to avoid, is to go selectively, and if you go very selectively and you don't have those distal anastomosis, you can embolize safely, but the other, you need to have some tips and tricks to manage all to manage those branches. You have already seen those images. It's very important to identify the origin of the prostatic artery, but those anastomosis will be only seen if you go and inject selectively in the prostatic artery, and you see connection between bladder, rectum, and I would say the most dangerous one is one with the pineal artery. We have seen the study showing that if you use Lumi beads, you will see like 100% of non-target embolization. Is it shunt opening? Is it backflow? It's not been really well documented, but probably because the beads that been used were really small, and the shunts were quite easy to be opened. And even there's those non-target embolizations, there were no incidents, clinical incidents on patients, even those went into the pineal artery. So it's kind of confusing to see where all those beads go and if there's really an impact, clinical impact. So the anastomosis, in this paper, they try to make it. It's not me, sure. No. Okay, thank you. So they try to make a classification about how those anastomosis. So there's three types. Type 1, which is a direct anastomosis with a prostatic artery with another artery. Type 2 is you have a direct mesh but with different collaterals coming from anastomosis, and the type 3 is kind of a plexus. I will finish my talk. I'm Lebanese from originally from Lebanese, so we are used to this kind of accident. So type 3 is kind of plexus of multiple vessels injecting the anastomosis. So this is what's happened, and Jafar have really explained it before, that sometimes you start to embolize, everything is going okay, and that's when you need to listen to the patient. And the patient, while we're embolizing, he started, I have feeling some pain on my penis. And if you look, it opened during the embolization. So we really, and he came back 5 days after with some small local lesions that had been treated and healed in 2 weeks. We don't like this. But it could be also an impact on how you're treating patient. But if you look, this patient was in 2019. his right lobe was bigger than his left lobe, and we stopped embolizing the left lobe at the time because we didn't have more complication. And he came back 6 years after with a recurrency, and you see that the right lobe that really was weird when embolized with particles have really shrunk, but the left lobe was under embolized at that time, and he get bigger, and now he have more symptoms. So we went back and did embolize his Conbeam CT, and also I love Conbeam CT from the beginning, and we did embolize it with glue, and really it's like a huge trend now going with glue for such type of embolization. So does glue protect from this? Maybe it could reduce it, but it doesn't protect. If you look at the study by Romaric on more 100 patients, he said that 4% of the patient had additional embolization to avoid non-target embolization with glue, and even those that had 1% off, which is the norm, which is the rate of pinal embolization. So here's some cases. If you have a direct, you could try to go this selectively, but maybe you could have some reflux. So it's quite easy. Sometimes you go and you can embolize. Mainly I use coils to embolize, but some people can use gel foam or like large packages of gel foam or other. But I like to put something that I see and have a mechanical occlusion. Here's another case of a replaced prostatic artery, no prostatic artery coming from the pelvis and bilateral, and you see you have a replaced coming from the common femoral artery. But when we inject and we do a Conbeam, we see there's a large artery going to the pinal artery. So in this case, we have I find, I don't know what you think, but I find we have more shunt and more different anatomy when it's coming from the common femoral artery. And in this case, we have also a nice shunt because one artery is giving the whole prostate, so it was easy to embolize in one way. Here's we have some coils in the collateral right here, and we did embolize the remaining part. Here's some anastomosis on with the rectal artery. It's easy to recognize. We have those straight arteries going down below the prostatic artery, and it was embolized also by coils and selectively to protect, and after we did embolize. Here's some with glue. Sometimes with glue you can control the injection, and you push slowly and you see you stop, but it also can occur to have also, so in this case we had no non-target embolization, but in this other case we see the embolization from the left side and right side with glue, and we see at the end when we control, we see some glue on the distal part with no clinical impact on this patient. So there's other way to do it is by monitoring the flow, and you could do it medically by injecting isoptine or verapamil. This theory have shown that it's safe and efficient. I find that have too many shunts. Probably they have no need for all type of shunts, but truly when you have this type of shunt with a pinal artery, you need really to reverse, and to be sure that the reverse is very, very effective before doing the embolization. So you could do it also medically, but you could also do it with blocking the flow with balloon catheter to when you inflate the balloon, your flow would go back backflow into the prostatic artery, and theoretically it would protect from a distal embolization. There were some catheters also that could reduce the flow and have like the secure catheter to protect the injection, having only the beads going and not going into in the right artery, not in the collaterals. But this catheter don't exist anymore. So there's also is easy and very cheap technique. I didn't use it. It's been reported, especially by our friend Khalil Hamza from Tunisia, and their study been done also in France. The tourniquet technique, put it on the basis of the penis and I found it uncomfortable. They said it's okay. I don't know if you have any experience. I don't have any experience on that. But I'd be worried if we do it with beads, because when you take the tourniquet out, the beads can go also. But if you do it with glue, probably it could be something quite effective. It's safe, and to occlude those anastomosis, no clinical impact on patient to have a proximal embolization. Even if you look on the erectile function, there's no impact on erectile function in patient with or without embolization of the of the anastomosis of the pineal artery. In this study, showing that you could do it without any risk, and it doesn't affect also the reduction of the IPSS score after embolization. You can have nice anastomosis, like in this patient, no protractor on the left side. I will go fast. And if you look at, it's not working. If you look, there was a huge anastomosis. I can maybe, and I will. There's a large anastomosis with the iliolumbar artery going and giving the anterior trunk. That would help us to go and embolize the whole prostatic artery, and here the result, and the patient did fine. After, you could also have one prostatic artery going through the anastomosis of the ureter artery in the prostatic artery and embolize the whole gland in one side. So in conclusion, we need to know what are the anastomosis. Not all of them are dangerous. There's this classification, type 1, type 2, type 3. I don't know. It's not been used by everybody. True, direct, and large anastomosis are probably dangerous and need to be embolized. We have two solutions. Could be mechanical. That's what I prefer, but it could also to be flow reverse medication or other, like balloon occlusion or tourniquet technique. Thank you.
Thank you, Hicham. A great presentation, despite the noises. It's my honor